Hello, everyone, and welcome. So this is the first Lungs on Fire speaker series session of 2026. My name is Stephanie Harvard, and I co-chair the Lungs on Fire Knowledge Mobilization Working Group. And this speaker series is a way for us to hear from people working in the area of lung health that have insights and expertise and evidence about wildfire smoke and interventions to combat the health effects of wildfire smoke, which is, of course, the focus of the Lungs on Fire project. Behind me, you'll see that I have the background of the University of British Columbia. I want to acknowledge that we do work on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh people. I do encourage you to put in the chat a note of where you're calling in from. We have an excellent speaker with us today. I remember seeing Stephanie Holm speak. I think it was about a year and a half ago. You're an excellent speaker, and I'm really looking forward to hearing more from you. Stephanie is an environmental epidemiologist as well as a pediatrician. And last time I saw you spoke, you did a great job of explaining your background. So I'm not going to take your thunder from you. I trust you to do that for us. But I just want to introduce you by saying this is a person with really germane, relevant expertise to the Lungs on Fire project. And I'm happy that today you're going to address the topic of masking. And this was a topic that was ranked very highly by the folks involved with the CAM working group, because we hear a lot about masking, and there are a lot of different perspectives out there about the evidence and about the benefits and potential harms of masking, and does this work in different populations, et cetera. So we're really thrilled to have you here with us today. And without further ado, I'd like to invite you to put up your slides. Oh, and one last note so that everybody knows what to expect. The format of this speaker series is to let the speaker go for 45 minutes to an hour, and then for us to have up to 30 minutes of discussion. And if we end before that, that's all fine. We'll go with a vibes-based approach. So thanks so much, Stephanie, for being here.
Absolutely. Thank you for having me. Thrilled to be here today. Yeah, I won't spend super long on my background, but just so folks know kind of where I'm approaching this topic from. So as other Stephanie said, I am a pediatrician and occupational environmental medicine doc, as well as an environmental epidemiologist. I worked for about a decade at the University of California, San Francisco, where, among other things, I was the director of the Western States Pediatric Environmental Health Specialty Unit. I add that in just because that group works on a lot of public health communication and education, both for health providers and the public, on really anything pediatric environmental health. But because our region included California and Hawaii, as well as the Pacific Islands, wildfires were a big topic for us. Certainly a lot of need. And I really got pulled into the masking and respirator side of things, I guess quite a while ago now, partially because families in our region were getting just really conflicting advice. So one of the stories I often tell is that during the 2018 Camp Fire, there was a local fire department handing out N95s, including to kids, and telling people that they should wear them. And one of the local public health people on the radio, like literally at the same time, saying that children, I'm being a little bit exaggerating here, but basically saying your kid would die if you ever put an N95 on them. And so we were getting all of these like parents and teachers calling us being like, we're very confused. And it was like, yeah, I understand why you're very confused. You're getting some really conflicting messaging. And so I sort of started to dig into that world in that setting, and have gotten just the lovely opportunity since to get to learn from folks who do all kinds of respirator stuff, like at all kinds of different facets. So I served on a National Academies of Science, Engineering, and Medicine consensus committee a few years ago that was focused on mask and respirator use for the general public, as well as for workers who aren't covered by programs. But through that, I got to be sort of the pediatrics person, and get to interface with all these folks that do all kinds of different things related to respirators. And then after that, I'm now on the standing committee on personal protective equipment through the National Academies. And then I've gotten pulled into a variety of other things, International Society of Respiratory Protection and blah, blah, blah. Anyways, short version being, I've sort of become one of the pediatricians in this space that actually has worked here a fair amount, because that's not something that's normal in pediatric training, or honestly in occupational environmental medicine training either, which is pretty crazy when you think about it. So sort of trying to bring all of that knowledge that I've learned through this process. All right. So we are going to talk a little bit about some basics of masks versus respirators and respiratory protection regulations. Apologies to anyone for whom some of this seems basic, but I realized when I got into this space that there was like so much vocabulary and kind of just basics that was assumed that everyone knew that I absolutely did not. And so trying to sort of bring you all along to share some of that knowledge base. Talk a little bit about the evidence for use in wildfire smoke situations. And then because I'm a pediatrician and this is my personal soapbox, you get to hear a little bit about why kids are especially vulnerable and what we know about respirator use for kids, because that's really a space that I'm active in. There are a few efforts going on. I'll tell you about those in a minute. What I'm not going to do is I'm making a huge assumption here, which I think for this audience is okay. But usually I would start with like a bunch of wildfire smoke background and what the health effects of wildfire smoke are and all that kind of stuff. I'm just baseline assuming that you all are very familiar with that. I think that's probably a reasonable assumption for this group, but obviously, we can chat about any questions related to that at the end as well. All right. So there's actually a really lovely, I think it's a handout from the Public Health Agency of Canada describing different kinds of what they'll call masks. And I say that sort of, with air quotes because the folks who are in the respiratory protection world, the industrial hygienists and those kind of people who've worked there for a really long time get very, very frustrated when people refer to a respirator as a mask. And I will say, when I first started working in this space, I kind of had a bit of an internal eye roll where I was like, yeah, okay, like I understand that you have this technical term that you want to use, but like that term means nothing to a bunch of members of the public. And in some cases can be very confusing, right? There are lots of members of the public who, when you say respirator, think of what I would call a hospital ventilator, right? Which is something entirely different. But I will say, having been in this space for a while, I've sort of come to realize that a lot of that fervor comes from a history of really fighting for worker protections and making sure that people are well protected and understanding that you need this regulatory framework and process surrounding all of this to make sure that people are adequately protected. So just to sort of, say that up front, that when I say respirator, I really mean respirator, and I generally don't use the term mask if I'm meaning respirator. So respirators specifically are designed to protect people from inhaled hazards. They don't have to be, but they're generally made from melt-blown polypropylene. So this is like a non-woven, sort of microscopic, just intertwined fibers. They, in addition to capturing particles by impaction, right? So just like big particles hit the material, or diffusion, which is where your little particles, because of Brownian motion, are bouncing around and can land on the surface. They also have an electrostatic charge, and so they pick up particles that way as well. And so you've got sort of these three different mechanisms working. They are designed to be a snug fit to the face. We'll talk a lot more about that in a little bit. And they really come out of the occupational space, as I was saying. And so most of the regulatory structures that are built around these assume use in an occupational setting with a variety of tools and resources available to you that would be available in an occupational setting. There are a number of different regulatory frameworks around the world for these. I think there are a lot of similarities, and we'll talk about those, but I think sometimes people think of these as entirely interchangeable, and they're really not. And so I do want us to think a little bit about what the differences are between the different kinds of certification for respirators. All right, and then just to sort of, what's the other side of that? Masks are basically anything else that goes on the face. And that's not to say that you can't have some potential respiratory protection from masks. As I say, folks who are really in the respiratory protection world get anxious when I say that. But it's not as though respirators are the only thing that could provide filtration, but they are the thing that has the most work and regulatory framework and all of these processes in place to make sure there are standards around those. Medical masks are generally designed for medical settings, and they collect droplets. They do have some amount of filtration ability as well. These are often also non-woven polypropylene kinds of materials. They are not as tightly regulated in terms of how much filtration they need to have. And so, some may actually have nearly as much filtration as an N95 type mask, type respirator, and some can have much less, and you just don't know because they're not designed for that. There are some new regulations coming in around those, particularly coming out of COVID. There was a desire to, improve the ability to have something that would be available for the public that maybe doesn't have to meet that 95 respirator kind of standard, but that could provide some protection. And then, these kinds of cloth masks, some of which may have filter layers, it's a bit of the Wild West, right? There are plenty of manufacturers who claim that their device can provide a lot of protection for folks. I always like to take manufacturer claims with a grain of salt, right? Because they have an incentive to tell you things work. And certainly when people are like in early COVID making things on their own, it's not as though I could walk into my local fabric store and say, aha, please point me to the aisle with the 95% filtering fabric that happens to have an electrostatic charge, right? Like there is no such fabric aisle. And so one of the big issues you have with those kinds of materials is that if they don't have that electrostatic component the way that respirators do, you're missing one of the big primary methods that particles get captured. And in fact, a lot of the particles that are sort of a particularly problematic size, so the kind of 0.3 micron particles, these are ones that can get all the way down deep in the respiratory tree. Those tend to be least well picked up by the diffusion and impaction. And so if you look at sort of graphs of which particle sizes are filtered well by different kinds of respirators or masks, there's often this big gap, right, in that really important particle range, which is best filled by electrostatic mechanisms. And so if you don't have that, you're missing a big important chunk. Okay, so I'm going to focus almost all of the rest of the time on respirators specifically. Happy to talk more about other kinds of masks later if that's helpful for people. But, it's really a big difference of the regulations and how much oversight and structure there is around testing for respirators compared to other kinds of masks, both, medical, surgical, and fabric, cloth, various things. Okay, maybe this is common knowledge for folks, but I definitely didn't feel like I had this clear in my head before I got into this space. So just to kind of lay some groundwork, the two main kinds of both regulations and standards around respiratory protection fall into two buckets. So the first is technical specifications, and that's really more about the products themselves. So that'll include information about like, detailed performance of the filtration material, right? For a NIOSH certified N95 in the US, for example, the filtration material has to filter 95% of particles within specific ranges. And that's true, many places. It includes information on product safety, materials, trade considerations like labeling, and there's very standardized testing methods. Most these kinds of respirators are tested at you don't need to know these details, but 85, liter per minute flow rate and da da da. Like there's all these very specifics. The second set of information are the selection and use guidance, and these tend to be industry specific, right? So there will be information about mining or information about different kinds of industries. And that really is looking at risk assessments based on the substances people are being exposed to, and determining what a safe level would be, considering an 8-hour workday, and then figuring out which products fit people well. And so it's really this combo of here's what we need to do in terms of making sure the existing products meet standards, and then the second set of guidelines for how to make sure people are getting and using things as well as possible. And I mentioned this comes out of a workplace background. The big requirement in the US, and I will talk about the US a fair bit, mostly actually because, not just because I've done a lot of work there, but mostly because NIOSH, the National Institute of Occupational Safety and Health, has really pioneered a really robust respiratory protection program. They have a personal protective technologies laboratory that does a bunch of work in the space. And so for a long time, they've really been sort of the example people hold up as the most rigorous framework for regulation and testing of respirators. That's particularly concerning in a world where the US is doing less and less science, and we can talk a little bit more about that in a minute. Although, yeah, anyways. But just to understand that that's where this comes out of, and the intent for a worker who's using a respirator as part of their job setting is that their employer is in charge of making sure that the respirator or respirators they are provided have the appropriate certifications. They have to fit test the worker to make sure it fits them adequately. And they're also responsible for worker training and helping the worker make decisions around when a product is no longer available to be used, right? So when it's gotten too overloaded with material and should be switched for a new one, for example. The reason that matters, and we talked a lot about this when I was on that National Academies Committee, is that without all of those components, you're sort of leaving a lot to the individual user, who understandably wouldn't be expected to have all the expertise to do a hazard assessment, to train themselves, right? All of this kind of stuff. And so understanding that we're really in a very different landscape without all of those components. Okay, and then second thing to talk about in terms of regulations and standards, and then I promise we'll leave this topic because I know it's a little dry. I'm also not making you memorize any numbers, so you're welcome. But in terms of other things to be aware of, so there's really a difference between regulatory frameworks and consensus standards. Regulatory frameworks are those things that are codified into law. They'll specify a conformity assessment process. That term basically is referring to when you have a manufacturer that makes a product, says, here's how well my product performs. Conformity assessment is the process built in to then check that all of that is true, right? That it actually meets all of the various requirements. And as I mentioned, NIOSH and the National Personal Protective Technologies Laboratory, NPPTL, has for a long time had the most robust version of that worldwide. And so, that'll include things like review of the manufacturer supplied documents, which also often includes third-party testing. They do some auditing and testing themselves. And their process also includes life cycle considerations. How do they make sure over the course of producing these products that the same standards are being met, all of those kinds of things. Sometimes those regulations target requirements for sale. Sometimes they target requirements for use. So what I mean by this is that one of actually the, I think, real problems with the way that NIOSH has set it up is that all of those are regulated around use. So I mentioned that the employer is responsible for making sure that their worker is using a certified product. That's what I mean when I say it's a requirement for use. Whereas in the European Union, for example, all of the regulatory frameworks are built around requirements for sale. So products can't be sold unless they meet those requirements. Whereas in the US, again, bit of a Wild West, anything can be sold. And it's really up to the employer to make sure that the individual employee is getting a certified product. So those are regulatory frameworks. Consensus standards are most often voluntary, but bring together a lot of scientific expertise, and frankly, sometimes also bring together those same government people who are responsible for regulatory frameworks. Um, but these are often used to fill gaps in the regulations and then sometimes later are incorporated into them. And so there's a number of bodies that work on these. ISO, the International Standards Organization, is one of the big ones. And they have, both of those kinds of specifications that I mentioned before, both the test and performance requirement things, and they also have information on selection and use guidance. And then they have a variety of others too, specifics of flame resistance and how exactly fit testing should be done and all of that kind of stuff. ASTM, which is the American Standards and something that starts with a T and an M, but they're the US component of ISO. One of the big things that they did recently post-COVID was come up with this barrier face covering standard that I mentioned before. And so the idea of that standard is that it is not a respirator. It does not have to meet specific respirator requirements, but that there could be these face coverings or masks that provide either a 20% filtration or a 50% filtration. With the idea being that, it could be helpful to have something on the market for the public that maybe is more comfortable than a respirator or, for whatever reason has other qualities that people like, but that provides at least some amount of filtration. And so they've recently come out with that standard. My colleagues in the industry tell me that no one's actually making anything to that standard yet, or testing their products to that standard. So, it's a bit of a hypothetical advantage at this point, but hopefully, as a society, we're headed that way. ASTM also has a fit capability standard. So this kind of blew my mind when I first started working in this space. But in general, the regulations don't have particularly detailed requirements around making sure that your product actually fits people. So, there's really detailed information about exactly how much filtration the material has to provide, all that kind of stuff, but much less around if I'm someone with a big face, or I'm a tiny, little woman, or I'm a, whatever, all kinds of different facial configurations. There's a lot less around what percentage of the population you have to make sure your product fits. So to talk about that specifically for a minute, there is this panel that's used in lots of places around the world. Again, came from NIOSH in the US, and this is what's called the bivariate panel. Bivariate because it's based on two variables. Those are facial width or bizygomatic breadth to be most technical, and so it's a caliper measurement here on the face. And then face length, which is the Menton-Sellian length, so from here on the nose to the bottom of the chin. And so you're looking at those two facial measurements. And what they've done is they've divided adult faces into these boxes that you can see on the image to try and sort of capture the overall distribution of human face sizes. The one that's used currently is based on a 2003 survey of respirator users. And so it's intended to be representative of the working population, right? So not necessarily even all adults, but the working population. There was an effort made to stratify and weight it so that it was a racial and ethnic group that was representative of the US population. And it covers, I have that backwards, 99% of the male workforce and 97% of the female workforce. But this is actually only required to be used for elastomeric. So Adding my respirator glamour shots onto the slide. The top is me wearing an elastomeric, right? These are these reusable respirators that you more often see in industry that have cartridges or like round filters that you can put onto them. There are lots of advantages to those in industry, right? You can have different kinds of uh, cartridges or filters. So there are particle ones, but there's also things that will pick up different kinds of gases. They're reusable, right? The um, bulk of that device that I'm wearing is made of plastic and various reusable materials, and you can just switch out the filtration. So this panel for face sizes is codified and required to be used for testing of elastomeric respirators. It is not required for use for what people in the industry will call filtering face piece respirators. And so that's your N95s, KN95s, et cetera, right? Like that class. So sometimes people will still consider it, right? But it's not required for those kinds of respirators. And so I think understanding that that is not a requirement is helpful in contextualizing the various kinds of products that are available on the market. So I mentioned that we'd talk about the different standards worldwide a little bit. Again, not going to make you memorize any of the numbers on this chart, but just calling out. So this is showing sort of the set of respirators that have 94 or 95% efficient filtration material. And there's different columns for the different countries' regulations. So this left one here is the NIOSH N95. FFP2 is a very similar respirator in Europe. The KN95 out of China, the P2 in Australia and New Zealand, the Korean first class respirator, the DS2 in Japan, and the PFF2 in... Can't remember where that is. In any case, basically all of them are tested at a very high flow rate. So 85, 90, 95 liters per minute. For context, right? A usual adult breathing minute ventilation is like 5 to 8 liters per minute. So we're testing these at wildly higher flow rates. That's somewhat intentional, right? The idea here was that when workers are doing an activity that's making them breathe really hard, you want to make sure that even at those higher respiratory rates and minute ventilation, that they are still being well protected. But it does mean that, especially when we think about the public and kind of the potential for using these in everyday life, we're using data that's extrapolated way out to a situation that's entirely different than what you would expect people to be breathing in normal conditions. Many of these include total inward leakage tests. This is trying to get at that question of, how many faces does the respirator fit? The NIOSH certification does not include total inward leakage. There was actually sort of a big contentious political thing in the aughts where there was an effort to try and incorporate this into the regulations, and there was pushback from members of industry saying that it was too onerous to try and test these, and so that's definitely an evolving space. But some of the standards worldwide do include those. That's often wanting there to be roughly less than 10% inward leakage around the edges of a product. And then there's also differences in the requirements for inhalation resistance. So one of the big things that matters for comfort and for people's ability to use a respirator is how hard it is to breathe through, right? How much of a pressure drop you get across the material. And there's quite a wide range in the rules for these. So anything from FFP2, wanting there to be a 70 Pascal drop tested at a lower flow rate, up to a 240 Pascal drop at the sort of standard high flow rate that I mentioned, whereas the NIOSH one is 343 Pascals. So we're looking at things that are like, 1.5 times different in terms of what's tolerated. And part of that is because there's not a huge amount of physiologic data that these are based on. They tend to come out of historically we had this thing and it worked, and so then it needs to be at least that thing or better. Um, so there is a lot of variety in these. And then many of them don't include any kind of carbon dioxide clearance requirement either. We can talk a bit more about that in a minute, but you may remember from some of the kerfuffle around COVID times that devices with an exhalation valve accumulate less carbon dioxide within them. And there's been a lot of discussion around how much that makes a difference for different facets of the use. To bring it to stuff locally, there is a relatively new, I think it was 2022, respirator standard out of the Canadian Standards Association. I threw it up on here next to the various regulations, just noting explicitly that the other things on here are regulations, they're codified. This one is a standard. It is sort of slowly being incorporated into a bunch of regulations, sort of federally and provincially at different places. So I think it's headed that direction, but it certainly initially is and started as a standard. It is very similar to the NIOSH standard out of the US. So pretty much, the testing flow rate, the filtration requirements, those are all the same as in the US. The folks that led this effort used it as an opportunity to make a few improvements, which is great. So one is that the CSA respirators actually have a fit capability requirement. So thinking back to that NIOSH bivariate panel that I showed you a minute ago, there's requirements of how many people for each of those boxes, how many people need to be tested within each of those boxes. And they're required to achieve what's called a fit factor of 100 for every person that's tested. Fit factors are basically the inverse of the proportion. So a fit factor of 100 means that for every 100 particles outside the respirator, one makes it inside, right? So you've got 1/100th, or that's called a fit factor of 100. And so that component, that fit capability component, basically saying that the product has to fit a wide variety of faces, is actually baked into this standard. It also includes information about that at least one person has to wear glasses of the people tested, because it turns out that was not necessarily ever tested anywhere else. And as you can see from the folks who are sharing their video on this call, there are people in the world that wear glasses. This is a common thing. And then there's also an improvement in the sort of requirements and labeling for inhalation and exhalation resistance. And so the CSA standard includes 3 different levels. So one that's the same as the NIOSH, that's the less than 343 pascals. But then also a 175 or a 100 pascal version, basically meaning that the Canadian standard has a requirement to say, hey, look, this is the version that is similar to the NIOSH N95. There are these 2 others that are also the same in terms of filtration performance, but are going to be easier to breathe through. And that's why you see, if you've looked at the labeling for any of these, there'll be a CA N95, but then there's another number. That other number is referring to the to the inhalation resistance. So a CA N95 343 has a 343, or meets the standard for the 343 pascal inhalation resistance. If you want one that's going to be easier to breathe through, you want to look for a CA N95 175 or a CA N95 100. I obviously don't know the full landscape of products available, but I haven't seen a lot of products that fall into those latter 2 categories yet. The hope is that, with this new standard out there, that those will be increasingly available. But it's at least, it's encouraging that the standards are moving this direction, right? That there's something in the labeling that'll be able to tell people, hey, this one might be easier to breathe through than this other product. Because right now that isn't there, right? You really can't figure that out as a consumer. All right, so to sum up all that regulatory stuff. Um, Industry and governments are actually really good at making and testing filter material to specific standards. There are lots of products that don't meet standards. There's certainly lots of issues around counterfeit devices, all of those kinds of things. Um, but the industry as a whole, knows how to make filter material that works very well and has really detailed processes, exactly what flow rates, exactly how you test the material, all of this for the filtration material. But there's a lot more variety in the regulatory frameworks and standards around fit. Um, Fit testing is not required in the technical specifications for FFRs like N95s through NIOSH. As I mentioned, that bivariate grid exists, but it's not used for things like N95s. And looking more broadly worldwide, there's a lot of international respirators like the KN95 out of China that are not designed for a tight fit. One of the things that is kind of the saving grace for the NIOSH N95 is that because employers bear the responsibility for making sure their employees have a respirator that fits them, they do that fit testing. And so there's some market pressure where if your product is not going to fit workers, the employer is going to stop buying it, right? That component is not set up in that same way in China. And so there isn't that same kind of market pressure. And that's why, many folks noticed during COVID that there were all of these ear loop KN95s available. And a lot of folks like them better, right? Because they're like, it doesn't push on my face. It's so much more comfortable. It's not smushing my nose. The problem is, the reason it's more comfortable is because it's working less well. You need that tight seal. Reminder that respiratory protection grew out of a mining and industrial background. And because of that, there are some assumptions baked in. So with a tested fit factor of 100, so meaning if I am a worker and I go in and get a quantitative fit test, not a qualitative. So many of you who work in medical settings may have had a qualitative fit test. That's where there are a few ways to do it, but most commonly they put a hood on top of you. They make you read the rainbow passage, which I don't understand how this one particular passage got baked into the testing, but sure. And you read this, and then you're trying to see if you can taste a, a tracer that's squirted into the hood while you're wearing the N95. That's a qualitative test. There are also quantitative tests like the one pictured here, where you have a particle counter with both an ambient intake and then an intake that goes inside the mask. And it's literally measuring that difference, right? What's the concentration outside versus inside? Okay, so for an individual tested with a fit factor of 100 and them being in a respiratory protection program, right? So getting the training, all of the oversight, what they call the assigned protection factor, meaning the protection someone's expected to actually receive from that device is 10, or getting 1/10 of the material, right? So people say, oh, well, N95 protects me 95%. Not really. The assumption is that if you were fit tested, an N95 makes it so that 1/10 or 10% of the particles get to you, not 5%. And I say that because, again, this is the difference between being tested in a somewhat idealized scenario and wearing something in real life, right? You fidget, you sweat, etc. And so the assumption is that you get less protection in a real world setting than when you're actually being tested for fit. Okay, so I've hinted at this already, but really the key things to think about anytime you're talking about respiratory protection are filtration and leakage, right? How much goes through the material in the device and how much goes around it. And the leakage really is dependent on fit. This image on the left makes me sad every time I see it. This is from an NGO mask distribution effort during COVID in Delhi. And this is the look, thumbs up, all of these wonderful children have masks. And obviously these are masks, not respirators. But you can look at these kids and see just how awful the fit of these are, right? You can see the giant gaps on the sides of the faces. Yeah, it makes me sad. And the graph on the right is from an article looking at how many particles reach someone wearing a respirator or a mask through different methods. So at the top, they're showing how much gets through the filter medium, and it's, depending on the size diameter of the particle, that's what's on the x-axis. The percent getting through is somewhere between, like 0.01 something to 1%, right? At the different particle sizes. The portion coming through the face seal leakage is somewhere more in the range of like 2 to 5%. And so, I mentioned that there's this huge focus and lots of strict regulations around the material, but less so around the fit. And the real problem with that is that it's actually the fit that matters the most in terms of exposing you to particles, because that's more of where those particles are coming from. For comparison, the data for a surgical mask or below, please note that the y-axes are wildly different here, like 10 times different. So the amount getting through the filter medium of a surgical mask that they tested was, 5 to 10%. The amount coming in around through face seal leakage is in the range of 20 to 50%. That's still, that's not no benefit, right? They're still getting some filtration benefit wearing a surgical mask. But in both cases, it's the leakage that's the biggest factor, and then some coming through the material, less of that coming through the material for a respirator compared to a surgical mask. All right. So there are a number of studies looking at direct health evidence for public use of respirators against ambient pollution. Understanding that there are a lot fewer safeguards, as we mentioned, than there are in a workplace setting. But so, for example, there's been some controlled human experiments in China looking at real and sham respirator use during severe pollution events, and shown things like those who are wearing respirators have decreased airways inflammation, less endothelial dysfunction, lower blood pressure. In a group specifically of heart disease patients, there's a group that showed that they had fewer subjective symptoms and improved indicators of cardiovascular health, so things like heart rate variability. Like I said, there are a number of those sort of looking at ambient air pollution, and part of that is that ambient air pollution is pretty predictable, right? There are a number of places around the world that have really bad ambient air pollution on an ongoing basis, and so it's relatively easy to study and bring in participants and know that you'll have poor ambient air pollution to work with in a real world setting, or to bring them into a controlled laboratory and be able to give specific exposures. There are not, unfortunately, specific studies like that available in wildfire smoke settings yet. So this image I used on the left is from something written by probably some of the folks on this call, but it was a National Collaborating Center for Environmental Health Rapid Review recently. This is their image, and they really called out that there are no studies directly measuring human health endpoints using N95s during a wildfire event. There are some sort of related pieces of evidence. So there are kind of much less robust survey studies talking to folks about what actions they took during wildfire smoke events, and noting that people who wear masks most often when they're more clearly wearing N95s, although often these surveys don't necessarily do a good job of teasing those out, that those people report fewer symptoms. And then there have been a couple of modeling studies recently, sort of taking what we know about health risks of particulate pollution and saying, okay, if we were to apply what we know from those health risks of pollution, what the levels are during wildfire smoke events, what we know the benefits can be from N95 respirators, what would you expect to happen in a wildfire setting? And so there's a group that just a couple years ago looked at cardiovascular disease in adults. Heart attacks, myocardial infarctions go up during wildfire smoke events. And so they were looking at what the number needed to treat would be in order to prevent a myocardial infarction, which, their conclusion was that you have to treat a lot of members of the general public, which makes sense, right? If you're looking at all comers, not necessarily folks who are particularly susceptible, you would need to have almost 90,000 people using a respirator for some portion of a 2-week wildfire smoke event to prevent a heart attack. But then if you're looking at the high risk folks, it's much smaller, right? So if they're using a device that provides a 50% reduction in their exposure, which could be something like one of those ASTM barrier face coverings, right? If those come to the market, that you would need about 13,000 high risk people to be using that. But that if you get to higher proportions of filtration, right, better performing devices, that the number of people needed to treat then goes down. So if, for example, the decrease is 75%, then you need about 9,000 high-risk people wearing a respirator to prevent a myocardial infarction. And then there's another group that looked at masks and respirators to decrease respiratory admissions. So this was looking at the state of Washington wildfire season in 2012, which was a particularly bad one. And this group took actually sort of a wider view, looking not only at respirators, but also at some of the cloth masks and surgical masks. And one of the cool things they did, this graph on the left, was actually testing the filtration material for those products at more typical flow rates, right? Flow rates that are more representative of someone breathing at rest or mild exertion, as opposed to these crazy high flow rates that are baked into the standards. And so that graph on the left is showing the protection factor that those different kinds of devices gave. The natural fibers, so like cotton or like woven fiber, woven or knit fiber masks, and the surgical masks had very low protection factors, close to 1, meaning not getting filtration from those. The synthetic ones had a little bit higher, but still not much. And then the N95s, more consistent with what you might expect, had the higher protection factors. It varies a little bit during different settings, right? So the 3 different colored bars are urban particulates versus wildfire particulates versus dust. And that makes sense, right? I think we're probably all pretty familiar with the fact that particles are this heterogeneous soup, right? They're defined by diameter. And so we treat them as if they're all like perfect spheres at the same diameter, but of course that's not true. And so the exact makeup of those can vary a lot. So then the graph on the right is looking at what you might expect in the decrease, what you might expect in terms of respiratory hospital admissions if populations were using these different kinds of products. And so you've got, again, the natural synthetic surgical masks and then the N95 on the far right. And this group really tried to bake in some practical assumptions to their modeling. And so they simulated data where 40 to 80% of the population was wearing their device 40 to 80% of the time, trying to recognize that nobody's going to have perfect compliance. Nobody's going to, we're not going to convince every member of the population, et cetera. And they found that, were there to be widespread use during that 2012 wildfire season, you would have expected about widespread use of N95s, you would have expected about a 30% decrease in respiratory admissions. And so that's substantial, right? Especially when we're thinking at a population level in terms of cost to health systems and all of that kind of stuff. That's a substantial number. Again, it's modeled data. We need more specific health point end data related to N95 use, both in adults and in kids. But everything we have so far from related pieces of information really supports some potential decreases in health effects related to their use. And then, despite some of the fervor during COVID, the safety data in adults for respiratory protection use for use of respirators, those data are really robust, right? These have been used in a workplace setting for a very, very long time. And when you look at all kinds of physiologic parameters among respirator users, there's really minimal change. And in fact, there's a lovely review that was just done a couple years ago by Phil Harbour, who's one of the sort of giants in terms of the safety of respirators field. He's done a lot of lab work and human testing of these. He and some colleagues wrote a review recently to, I think, provide a scientific rebuttal to some of the fervor that happened during COVID, basically showing, look, the literature that we have really supports that there's minimal change in all the things we can measure, right? So heart rate, respiratory rate, blood pressure, that even if you're using a respirator for a long time, those things don't change very much. There are some increases in end-tidal carbon dioxide, so the amount that's accumulating within the device itself. That's partially a function of increased dead space. The amount that's being breathed in and out that doesn't participate in gas exchange. But those increases in end-tidal 2 are usually quite small. I'll note that they're also hard to measure. The act of putting in the kinds of measurement equipment that allows you to measure that end-tidal CO2 can actually change it, right? It's the sort of Schrodinger problem that by measuring it, we're changing the value itself. But there's generally no changes in oxygenation, so people's ability to get oxygen to themselves and their organs. And often actually when things like blood gases are measured to actually look at the changes in CO2 within the wearer themselves, there's little or no change, even if you're seeing the end-tidal CO2 elevate within the respirator. There was a nice study about a decade ago looking at ICU nurses that showed that there was an increase in PCO2, but it was small. It was statistically significant, but quite small, so not clear if it's clinically significant. And these were for ICU nurses wearing N95s for more than 12 hours. So when we think about this in terms of the general public, that's not representative of what you would expect a general use pattern to be, even for someone that's wearing it a lot in a bad wildfire event. And then recent meta-analyses have also shown no effect on exercise performance. I'll take that with a grain of salt. I do think it would make sense that at very high exercise loads, you would expect there to be some changes. But, when people are doing exercise testing in PF labs and all this kind of stuff, we're generally not seeing changes in exercise performance. All right, so that's the information on adults. I'm going to pivot to kids really quick, and I'll keep it brief because I know I'm approaching time. I always get excited and then just talk more. So really quickly, why are kids uniquely vulnerable to a wide variety of environmental health hazards, but specifically wildfire smoke? So one is they have behaviors and preferences that increase their exposure. So for wildfires specifically, the fact that kids are outdoors more, the fact that kids are more active, right? That's a good thing. We have an obesity problem. Kids should be getting out and being active. They shouldn't be sitting at a desk all day like me, right? But that does mean that they're going to be having a higher minute ventilation and then breathing in more of the wildfire smoke and other pollution. Kids have differences in their physiology, things like metabolic differences and differences in how they excrete compounds that increase the dose they get. And so back to the concept of minute ventilation for a second, kids have a higher minute ventilation compared to their body size. They bring in more air relative to their body size than adults. And so even in the same exposure setting, right, if I'm in a space with my 12-year-old daughter and with my 6-month-old nephew, the baby's going to have a higher dose breathing the same air compared to my daughter or to me. Kids have unique windows of growth and development. And so, if you perturb a growing system and change a growth trajectory, you can have these outsized effects that build up over time compared to sort of a one-time insult on I'll call adults a more static system. And then kids, of course, have less ability to control their environments. And that's sort of, micro level and macro level, right? Kids aren't the ones making policies, they aren't voting. But also they can't necessarily, they don't have the agency to tell the teacher in their classroom, like, oh, actually, I'm having trouble breathing ever since that window got opened. I do much better when we're getting filtered air through the HVAC system, right? They don't have control even in those smaller settings. So for all those reasons, kids are particularly vulnerable. You may know that in North America, we don't have respirators that are certified for children. There are some in some places in the world, but we don't have them here. Um, Interestingly, and you don't have to spend too much time looking at the details of this, but interestingly, many children do fit onto the NIOSH bivariate facial grid. So just to orient you for a second, this is just plotting out child face data from a number of different cohorts. A range of ages. Many of them start at age like 2, 3, 4, and then going up into teenage years. And basically what you see is that there's sort of, if you look at the width by length, there's sort of this consistent pattern of how average faces grow during childhood. And the means end up on the bivariate facial grid sometime in adolescence, depending on exactly which population you're looking at, different, racial ethnic groups, all of that. But interestingly, actually, so this is, looking at the averages at various ages, the distributions are much wider. So this is pulling from a subset of that same data I showed on the last slide, but in this case, including error bars that show the width of the 95% of the population. So this isn't an error bar on the mean. It's rather a distribution of where 95% of the kids at that age fall. And so, you can see these error bars are really wide. So for example, 3-year-olds here range from, 95 millimeter facial width up to almost 120. And, on the low end, that's smaller than the youngest kids. And on the high end, that's bigger than the mean like 10-year-old face, right? And so even though there is this pattern of growth that marches forward, there's actually way more variability within a specific age than between ages. And so I think that's really important to know. Folks often want to really age band recommendations for kids. And I think this, and there are other things, but this is a good reminder of why it really should be adapted to the specific kid, right? I like to joke, my daughter has a very large head. And when she was age 4, she was in an adult medium ski helmet. My mother wears an adult small ski helmet, right? And obviously that's head size, not face shape. But I think that gives you a good sense of like, you can have these young kids with very large faces that can fit the existing adult products that are out there. And others that will better fit the kids' size respirators. And so it really should be targeted based on the individual. I won't spend a lot of time on it, but there are at least a few studies looking at fit testing of children. It depends on the products. As you would expect based on literature in adults, products that use ear loops like this one pictured, which is from a study in Indonesia and Nepal, tend to have lower fit factors than products that are more tightly secured to the face. Basically, all of the things you would expect based on the adult literature also apply to kids. It is possible to get a good fit for kids, both with child design products and with some adult small products, again, depending on the kid themselves. I'm going to just skip it for right now. I'm happy to talk more about it later if you like, but there's very similar data on safety for kids as compared to adults. Some changes in physiologic parameters, slight increases in things like heart rate and respiratory rate, but well within the normal range for kids. So really quick, just before I finish, I'll just say there's some really exciting stuff happening in the respiratory protection for kids space. There's an ASTM public respirator standard that's been in the works that I'm not involved with, but I know is happening. And that's targeting the general public. And so the thought is that kids will be covered in that at least to some degree, even though it's not specifically targeted children. There's a research project called Face Up that is that one in Indonesia and Nepal that I mentioned, being done by some colleagues in the UK. And they are looking at fit of children's respirator products. But then they've also directed a lot of their efforts towards standards and regulatory efforts. And so many folks in that project, and then some others of us that have gotten looped in from around the world, are involved in writing some guidance for UNICEF about respiratory protection for children and respirator use in children. So this picture is actually a group of us in Milton, Ontario, a month ago, 2 months ago, working on the initial sort of kickoff for that UNICEF guidance. And then there's also a group of us writing a children's respirator standard for ISO, the International Standards Organization. And so the hope is that, as these standards come out, that they'll then be available to be incorporated into regulations going forward. All right, so to just end with the super practical stuff, this is a lovely figure from the BC CDC wildfire fact sheet. So maybe some of you have seen it before. But I think it does a really nice job of showing a couple of things. So one, you want to make sure you're choosing the product that has the best fit to your face that you can. Obviously, we could talk lots about this. There are plenty of issues around that, right? But if you have multiple things available to you, which not everyone does, you want to choose the one that fits the best to your face as possible. You want to put it on and arrange the straps. If you have ones with head straps like NIOSH N95s, you want one to be above and one to be below your ears. That's how they hold best to the face. Something that many, many people do wrong. Most folks, when they put on a respirator, the sort of initial inclination is to grab the nose clip like this and pinch it. When you do that, when you're pinching it with one hand, finger to thumb like that, you're much more likely to end up with an air gap right at the sort of top bridge of your nose. And now you have an extra area of leakage. As we talked about before, any amount of leakage is much more likely to introduce particles into the mask. And so you actually really want to use two hands. You want to have, fingers from your right hand pushing down the metal nose clip on the right side of your face, and the left hand pushing it down on the left side of your face. And then every time you wear one, you also want to test for leaks. So that's, breathing in and out and feeling around the edge. Do I feel airflow coming around the edges of my respirator? If I'm wearing glasses, do I see them fog up as I breathe, right? That's a good indicator that you've got one of those airflow gaps. And also you should feel the product collapse slightly on your face when you inhale, right? You're breathing through this full filter, and so it should sort of come in slightly as you inhale. I will say, just to leave you with one other piece of data, there was a study a couple years ago where they looked at how good of a job people do at predicting their own fit using a seal check. And it's not great. I still think seal checks are important because if you notice an airflow problem and you're able to make an adjustment, that can only help, right? And in fact, when people say their respirator does not fit them well, they're usually right. So in this study, there was actually 100% accuracy when the subject said, nope, this doesn't fit me. They were right. It didn't fit them. The problem is that there was only 35% accuracy when predicting a good fit. So everybody who said, nope, it doesn't fit me was right. But of the people who said, yeah, this fits me, it's great, only about a third of them were actually getting a good seal, a good fit on that respirator. It is possible for that to be improved. There are groups, Phil Harbor's group, for example, did a video training method where they got people able to better fit to themselves. So, I think that's an education gap more than anything else. But I do think it's important to remember. And then just to leave you with, because I always feel a little bit guilty talking only about respirators, PPE is supposed to be at the bottom of the hierarchy of controls, right? So this is this concept from industrial hygiene, where if you're trying to protect workers or people from a hazard, you really want to first think about, can we eliminate that hazard? If we can't eliminate it entirely, can we substitute it with something that is less dangerous? If we can't do that, can we do some sort of engineering control? So that means something like, improved ventilation in a building or those kinds of things. If not, can we use some kind of administrative control, right? Have people spend less time in the hazardous environment. And then the last option is PPE, personal protective equipment. And so even though I've spent this whole time talking about masks, I don't want us to neglect those higher parts of the hierarchy of controls, right? And so for wildfire smoke, one of the big ones, and this ends up being an engineering control, is just making sure people have access to cleaner airspaces. And so this is my little graphic that I often use for folks when talking about making cleaner airspaces in your home. One of the best ways to do that is to change your filter in your air system to a MERV 13. That stands for minimum efficiency rating value of 13. The standard in homes is like a 6 to 8. MERV 13 has literally orders of magnitude better filtration. Portable air cleaners can be used. And of course, as lots of folks know, and I believe some of your folks have worked on projects related to these as well, you can also make these DIY fan filters that can work quite well, actually. So definitely important hierarchy of controls, but there is mounting evidence for respirator use. It's a more complex landscape than I wish it were. And I think, unfortunately, the COVID pandemic experience, while it taught a lot of people the words or some of the words for respirators, it really increased the confusion. And so I think we have a bit of a uphill battle as scientists working in this space to help folks understand what the landscape is, what we know, what we don't, right? But that also the things we don't know about respirators, there does need to be more data on fit for both adults and kids. There does need to be more safety data. But what we have so far suggests that they are safe to use and have some real advantages.
Thank you so much, Stephanie. I take it that'll wrap it up for now.
That'll wrap it up.
So I got some feedback based on our last series that it would be helpful for me to stop the recording before we do the discussion. And the idea was that would help encourage folks to comment and ask questions. So I'm going to stop the recording, and then I'm going to